I'm delighted today to be joined by Sam Evans, who's a consultant ophthalmologist whose clinical practice spans a very wide geographical area. Sam's also founded Lutra Health, a platform aimed at rethinking how patients relate through eye care pathways. And in addition, Sam has taken a very deliberately different approach to cataract care, including meeting many of his patients for the first time on the day of surgery. And I'm very keen to explore his journey as a consultant, the thinking behind what many may perceive as unconventional choices, and what he's learned trying to redesign systems that many of us take for granted. Sam Evans, welcome.
Hi, Simon. Nice to be here.
Sam, before we get into detail about systems and that sort of thing, can you talk us through your journey as a consultant thus far?
Yeah, for sure. I was appointed about 10 years ago in West Wales as a consultant in Carmarthen, which is a small town covering a very large area with very few consultants. Um, and so I had a very general practice there. I covered cataracts, oculoplastics, orbit, lacrimal, and glaucoma surgery for the most part. And I had a lovely time in Carmarthen, and I stayed there for about 4 or 5 years, I think. And then, for one reason or another, I decided to move home, which was South Devon, where I grew up, and I was really fortunate to be appointed in Exeter, a place that you and I know very well. And I joined the team there at Exeter just around or just before COVID hit us, and was part of the gang that were trying to deal with the consequences of that. And then um, I left the NHS altogether about 3 years ago, so I'm just in independent practice these days.
And you work over quite a wide geographical area now privately. How has that shaped the way that you think about patients' access, convenience, and the whole patient experience, if you like?
I think it's been very informative. I think one of the things it's shown me is that um, the challenges of being a patient, if you like, are very different in different parts of the country, and so what's right for patients in the southwest, where I have a practice, may not be what patients in West Wales, for example, are looking for. And so I think I've learned it's very important to sort of tailor your practice, tailor your offering, to the need in the communities that you're serving. For example, the challenge in rural areas particularly, and I tend to be in rural areas chiefly, is often access to care. It's often things like distance to travel, places that often patients with quite advanced disease, particularly in terms of glaucoma and plastics. So often presenting quite late, and that can present challenges, particularly in the private sector, where you may not have access to some of the interventions or sort of teams that you would do in the NHS. So it's been very instructive, having practice, as you say, across two very different areas.
And like father, like son, you're a congenital ophthalmologist, I think.
I am.
You've recently opened a new diagnostic facility in Plymouth, haven't you? What gap are you trying to fill there?
Yeah, that's right. So I've opened a practice called Devon Eyes down in Plymouth, and there's a couple of things I'm trying to do with it. Really, I think one of them is to provide a personal service from a sort of a local chap down in Plymouth. It's part of the world that I'm very fond of and passionate about, and I think I can offer something a little bit different to patients down here. And one of the other things that I'm trying to explore and keen to explore with Devon Eyes is I think it's partly a response to the sort of conglomeratization of ophthalmology that we see going on around us. I think it's very easy for all of us as individual surgeons with our individual, approaches to the problem to, working under a big brand, as it were, to get a little bit lost in that. And I think one of the beauties of being a consultant is being able to, be an individual. Ultimately, the relationship is a one-to-one relationship with your patient. It's based on trust and respect both ways, and that's something certainly that I'm very keen on in throughout my practice. And I'm keen that Devon Eyes becomes a home for ophthalmologists in the area who are keen to explore private practice, but perhaps want to try and do it their own way a little bit as well. So it's early days with Devon Eyes, but I'm trying to offer something a little bit different for patients and for my colleagues.
Well, the very best of luck with that. Just turning to your clinical philosophy, if you like, how would you describe yourself as a cataract surgeon, and what matters most to you when you're in the operating theatre?
I think I try really hard in all things to keep things simple. And you alluded at the start to my approach to cataract surgery. I believe that the thing that I do best is empathizing with patients and operating effectively and safely. And so those are the bits that I really focus on. And talking earlier on about patients coming from rural areas, I'm very aware that patients traveling a long distance, and I try to do things as efficiently as I can do. So the see and treat cataract model that you alluded to at the start is an example of that. I think I don't need to see a patient in the clinic in order to make a decision about the likely sort of validity of a listing decision. I think that one of the nice things about cataracts is that it's a symptomatic problem, and you can talk to people about their symptoms in the same way that you and I are talking now on video, or you can do it over the phone. You don't actually need to see them in the clinic. There are, of course, certain things that you do need to see and need the patient for and examine them, but that can all be done on the day of the operation. And so I've been using and developing this system where I essentially deconstruct the patient pathway in cataract surgery into two parts: a remote consultation, which is really based on understanding the patient's symptoms, and then if it sounds as though the problem is a cataract, and I have a referral from an optometrist confirming that they're not already pseudophakic, then then I'm happy to sort of go down the track of talking about cataract surgery, and obviously talk about risks and benefits and lens choices and everything else that you would normally talk about in a face-to-face environment, which really only leaves the examination to do, and doing that on the day means that my findings are fresh in my memory, so I know what their corneal endothelium looks like because I've only just looked at it. Uh, so I don't find that from a surgical point of view it's a compromise at all. But from a patient point of view, and to come back to what sort of cataract surgeon do I try to be, the patients really like it because they're making potentially only one trip in if we're doing bilateral surgery, one trip in, very short waiting list because they're not waiting for me to have a slot in clinic to see them. Um, it fits very well with our general experience of life, which is I have a problem, I'm going to fix it, and I'm going to get on with my life. And I think people wring their hands a little bit about us becoming simply technicians, and the art of the surgeon and everything else. And I don't believe that this approach threatens that at all. But it certainly means that the patient experience is a more straightforward one. And for my patient demographics, that seems to work very well.
Does that mean people don't get to see you in a pinstripe suit and look at your brass plaque in advance of the day of surgery, Sam?
Yeah, indeed. So I'm not. Yeah, I'm an open neck shirt sort of a person, I guess, and I think, as I say, I think at the end of the day, a patient who's got cataract, symptomatic cataract, they have a problem and they want their problem fixed by someone that they can trust, someone they can believe in, and I believe that a lot of the theatre which goes on around those, the pinstripe suit sort of approach is absolutely valid and reasonable for patients for whom that's important. I just find that for my patient group, that's not something that they see as important, which is lucky for me, really.
And is this approach applicable to premium lenses as well, or do you just stick to monofocal lenses?
No, so I don't tend to use multifocal lenses much in my practice, but that's more because I think that then they frequently don't they don't they don't solve a problem effectively. I think what they do is they move a problem. So in terms of side effect profile, in terms of neuroadaptation periods and that sort of thing. So I think I wouldn't be using multifocals anywhere if I saw my patients face to face. And it's also important to understand that the see and treat model does not mean that I dogmatically refuse to see patients before surgery. If there's a reason to see the patient, which might be they want to see me, or I think that there's more of a discussion to be had about a lens or an examination that needs to be done, then I of course will see them in the clinic in the normal way. I just find that for 90 odd percent of my patients, going back over 5 years now, thousands of phaco's, that the outcomes are just as good. The patients are just as happy, in fact, possibly happier because they've not needed to be coming in and out all of the time. Because it's easy for us to sit in clinic and say, well, I've got however many patients coming to see me today, and we think of the patient. The patient has probably had to ask their son, who probably lives 100 miles away, to take 2 days off work and figure out getting the kids to school just so they can bring mum into a clinic appointment in order for me to have a conversation with her, which I could have done over the telephone. So actually, the bit of the wedge that we see is actually it's the tip of the iceberg. To mix my metaphors a little bit. So to come back to your question, I use EDOF lenses increasingly. I've had very good results with those. I tend to get biometries either in the community. I have several optometry colleagues who have biometries in the community, and that works really nicely. Or for patients who live close to the hospital, they will come in and have their biometry done, and then the results are sent to me. And similarly for toric lenses, I probably put in, I don't know, 10% of my lenses are probably torics, I would think. And again, the conversation there is if a patient has more than 1.5 diopters of SIL on their subjective, I will talk to them about their ambitions or expectations for glasses wear after surgery. And if in the course of that conversation, it feels as though they don't want to wear glasses or that's an important issue for them, then I'll talk about torics. What I tend to find, and again, it's a reflection of my demographic, they tend to be cataract patients, is that most people don't mind wearing glasses for the distance. They just don't, they want to be able to drive. And I think, I don't know about you, but I think, bringing things right up to date, the changes that the government are talking about in terms of visual standards for driving for the over 70s, I've seen a significant number of patients coming just in the last couple of months with that as their main worry. If they have to wear glasses in order to achieve the driving vision, they're perfectly happy to. So you can certainly do premium lenses in this type of model, and you can certainly see your patients before surgery, as well. So.
It's certainly an approach that I've used myself once every now and again, but you're certainly very much the vanguard for this sort of thing. Do you ever feel slightly out on a limb, slightly exposed from a medical legal perspective, or are you totally comfortable with it?
I've always felt out on a limb and with my head too far above. In most things I've done, whether in medicine or not, and it's a recurrent issue that I have with myself, that I keep putting myself in these situations, but not from a medical legal point of view. I think ultimately, how do we judge the success of cataract surgery? Are the patients happy? Are the results what you expect? Is your complication rate acceptable? Do patients understand what's going to happen to them before they have it done? And on all of those measures, this approach is at least equivalent to the traditional face-to-face approach, with the exception of the patient, how am I making my patient happy? Part of it. The visual outcomes are the same. But I tend to find, again, patients who are traveling 2.5, 3 hours to come down from some rural idyll in the middle of nowhere are delighted if they only have to come once. So I don't have concerns from a medical legal point of view, and I'm not the only person doing it. In fact, it's an increasingly well used model both in the NHS and in the private sector, actually.
Now, the see and treat model and Lutra Health are obviously intimately related. What was the moment when you realized that you needed a sort of system solution, if you like, rather than just the personal workarounds that most of us would do. In fact, I have done. Was there an aha moment as such?
I think I did a pilot actually, or myself and my colleagues in Carmarthen did a pilot where we wanted to understand whether we could list patients. So this was before sin treatment. If we could list patients directly based on clinical information gathered by the optometrist and then subjective information from the patient, and that was the referral. So rather than having a GOS 18 referral, which essentially says, Mr. Madge has a cataract in his left eye, please can you see him? It would say, here's some information that he hasn't got Fuchs, he's not had a trab done, and then some information from the patient. And in that pilot in the NHS, we were listing about 70 or 75% of patients directly for surgery. Surgical outcomes were equivalent to those who'd been listed face to face. So we knew it was safe from that point of view. But there's a limit to what you can do on paper, and in fact, that was a bilingual paper document, so it was quite a meaty thing. And what I wanted to do was to give my patients in the private sector, I wanted to give them really good information delivered in a really accessible way. So, there is a paradox in delivering information to patients with poor vision, on paper. So I wanted initially, I got an app developed which had some videos of me explaining cataract surgery, had some walkarounds of the theatre and that sort of thing. But because of the background work with the enhanced referrals and also with glaucoma, follow-up data gathered in the community on a pro forma for patients who've been lost to follow-up, and we were just trying to understand who's at risk and who's not. And we sort of leveraged the optometry resource for that. Having made a digital asset with the videos, it was a pretty short jump to say, actually, if we put referrals onto this, if we put chronic disease care, if we developed a system which communicated directly with patients by text message and email, then we could collect pre and post-op proms, which is something the platform does fantastically. If we connect it with the optometrist, they can do examinations, they can upload visual field tests, they can upload DICOM files. And suddenly what you've got is, if you like, a dispersed diagnostic tool with the patient element in it, which means that whether you're using it for see and treat cataract pathways, as they do up in NHS Tayside, use Lutra, they've reduced their referral to treatment time from 180 odd days to 6 days-ish by, as I say, leveraging the resource in the community and the patients and having a digital tool, which in this case is Lutra, to bring all of that information in for the consultant to make decisions. Or if you're using it for traditional referrals, for patients in your clinic, for example, Simon, if you're using it, you'd still see your patients face to face. From your point of view, it wouldn't make much difference, but you'd have more information about the patient. The patient would have more information about you and about the decisions that they were going to need to make when they met you. So you have a more informed discussion. So your chair time with them is better. You're not starting from scratch. And similarly with chronic disease, I look after a lot of patients with glaucoma, and I do an awful lot of, visual fields, for example, often get done out in the community, interval tests, pressures, OCTs, the disc and fields. I'll often ask for stable patients for the optometrist to do that, and then they'll just send those resources in to me, so I can keep a watch on patients without them having to come into the clinic all the time. So really, it's not really reinventing the wheel. It's just putting a better hub on the wheel and letting it spin a bit more freely. It's been a lot of fun to do. It started out 4 or 5 years ago. Myself and Connor Ramsden, another consultant in Exeter, put it together. We've had venture capital funding. We've been procured in the NHS. We're deployed, across Specsavers and various other places. So it's been an adventure to do, and it's not been easy, but it's been good fun.
So a system that allows you to receive referral data, DICOM files, post-op, it satisfies the FIN network, it makes coffee. Is there any reason why people are not buying it at the moment?
I
Is it
think
lack of knowledge about it?
I mean, I don't. well, not after this podcast, Simon. I think it'll be widely known.
That's the spirit.
I think we are inherently as surgeons. We're wary of new things. We don't like change. We don't like being told that what we're doing could be improved. These are all features of my own character, and I share them with all of our colleagues, and for good reason. We've all seen things come along that promised the moon, and then all needed explanting, 2 years later and all of that. So I think we're rightly wary of things which appear to be revolutionary. And I think all I would say about Lutra and about all of these types of systems is that really all they're doing is they're just giving people better data. You choose what you do with that data. They don't compel you to change your practice. They just give you better information on which to base your conversations with your patients, with your optometric colleagues, and I'm quite sure that in 5, 10 years' time, we sit down and have another conversation about this. We will all be using systems like this. Now, I'd love it if it's the system that I've been involved with for sure, but if it's not, there we are. We gave it a bash, but it's very definitely the direction of travel, and I think it's likely to be more transformation in the real world for those of us in sort of non-academic, non-niche specialties than AI is, for example, because it simply allows us to operationalize what we do in a more efficient sort of a way. So yeah, so there's always reticence, there's always resistance when new tech comes along, and you always get your early adopters, and you get the guys who struggle at the back, and usually I'm one of them. But we'll see
Now,
what.
I would say that most doctors aren't desperately innovative, and most of us are probably quite resistant to change. What would you say to those surgeons who like the idea of what you've just said about all these incredible tools at their fingertips, but are nervous about stepping aside from the traditional pathway
In terms of the see and treat,
and adopting Lutra, the whole thing?
I mean, I think so. I would have. I mean, they're two different conversations. I think Lutra and any of these enhanced referral platforms. As I say, I would just look at them as the next step in the evolution from the feather and quill pen to the fax machine. I mean, it's only a few years ago they got rid of it. Fax machines in the NHS to email, and this is just another evolution in how we collect data. It's just that doing it on a platform like this allows you to send data out to your patients as well as receive it in from the optometrist. And I think that does really important things in terms of the relationship with the patient. The traditional referral pathway is between the optometrist and the ophthalmologist, and it doesn't include the person that it's about, which is the patient. And I think that's wrong. But it's for obvious reasons difficult to do it with paper. But on a digital platform, it's really simple to send patients' data, to collect patients' data back again. Surgical outcomes, for example, we collect pre and post-op PROMs. So as well as the acuities and refraction, which is obviously collected, we can actually see, are patients happier or not? Are their symptoms improved, which at the end of the day is the most important thing. I think on the see and treat side, I understand the resistance or the reticence, I should say. I understand the fear. I think all I would say is that certainly in my consultant career and even in my training career, we were all operating pooled lists. We were all operating patients who we hadn't seen in clinic ourselves. And depending on how you work and who you work with and the layout of your unit, you may well not examine the patient before you operate them. So you're going on the notes of someone who you may never have met, the SHO who's rotated out of the unit. So actually, is that less risky than having a good phone call with the patient yourself, communicating things in a way that you can be clear, makes sense to the patient, and then examining the patient 2 minutes before you operate them? I would argue that is a safer approach. And I think again, the invisible risks that we take or liberties that we take, and this is really more on the public side, those things that we do which insidiously delay treatment, like um, you know, seen a patient in the glaucoma clinic, they have a cataract, I'm going to send them to the cataract clinic to get assessed for a cataract. Who's to say that patient doesn't trip over, in 3 weeks' time and break the hip because they couldn't see the cat in front of them? Are
Absolutely.
we actually doing good by putting them through a inefficient cataract system? Would we not be doing them more benefit by saying, I'm a consultant ophthalmologist, you've got a cataract, I'll do it next week? So I think we have to the point about risk is you can't ever get rid of it. You move it to a place that you're comfortable with. And it would not be for me to tell my colleagues how they should run their practice. I wouldn't like it if people came along and told me how to run mine. But it's certainly it's not as much of a cavalier position as it might appear to be when you sort of think it through.
No, I'd agree with you there. A lot of people watching the podcast will be nervous about the Fin network, particularly if they own their own clinics and facilities, thanks to the CMA order finally coming to have its own teeth, shall we say. Lutra, Fin, does it satisfy everything that the Fin network requires? And how does it compare to other platforms like the RayProm software and so on?
Yeah, so it's a great question. Fin is a really fascinating organization, and the depth of data that they require is extraordinary, as any practice manager or surgeon will know. So on Lutra, we collect all sorts of pre and post op data, morbidities, outcomes, and so on, and then it's all available to export usually as a CSV, so just as a spreadsheet, and that it satisfies all of the NOD criteria. So you can submit directly to NOD, and you can obviously submit them to Fin as well. And I think that's potentially a really strong feature, as you say. What we need to be able to do as surgeons and as practice owners and managers is to show that we are doing the things that we need to be doing, and a system which collects that data essentially passively for you. If you've got your optometrists uploading the post-op results, and you've got your pre and post-op prom and your refraction accuracy against target data all being collected for you, and you can just dump it over to them, then I think that's an awful lot of admin headache which is dealt with.
Well done. You'll be very popular. Let's flip it around. A Lutra referral for Sam Evans pops in. The poor chap's got a cataract tomorrow. What lens are you going to have inserted in your own eye, Sam?
Well, I mean, I hope it won't be tomorrow. But I think I don't think there are any bad lenses out there. I think the law of the jungle is pretty active in terms of IOLs these days, and I don't think you can go far wrong with any of the lenses that are out there in our market. The ones that I tend to use, so I use a lot of premium monofocals, so I use Eye-Enhance a lot, and I use the Rayner EMV lens an awful lot, with a little bit of offset quite often for patients who are keen to reduce their need for glasses. And more recently, I've been using a few EDOFs, and the one that I've had some really reassuringly good results with is the Medicontour Elon lens, which is a little bit of a sort of, I suppose, a bit of a left field company. They're not in the mainstream, but I think they're making some really interesting lenses. They've actually got a very long track record of making good, reliable lenses. And so I would probably, if it was me, I'd probably go for an EDOF. And because I'm not an early adopter and I'm one of those irritating people that takes some time to decide, I'd probably watch the market a bit and see. But if it was tomorrow, I'd probably go for an Elon, I would think.
Without giving away the brand, would you be willing to talk about the experience you shared with me a few months ago, where you had an interesting experience implanting a lens that turned out to be somewhat different to what it was supposed to be?
I will, Simon, but it makes me very uncomfortable to do it because it was one of those sort of horror moments that you hope you never see. So this was a chap who was bilateral cataract, non-toric lenses, all very straightforward. First eye went fine, second eye went fine, and a preloaded lens. And the way that I do my lens checking, I'm really neurotic about making sure that it's not the wrong lens, as I'm sure we all are. And we all have our own systems for it.
Absolutely.
I don't write on the board because I think there's a risk of transcription error. So I always have the biometry next to me on my left-hand side, a trick that James Morgan taught me. And before fill the eye with Helon, ready to go. And then I'll ask the patient their date of birth and look at the biometry. And I think the chances of having two patients with the same name and the same date of birth are pretty slim. Obviously, the numbers have all been checked. So I'm always confident that it's the right lens, and then I check obviously on the lens packaging. Did all of that as usual, put the lens in, and as soon as it unfolded in the bag, um, all I could see was two toric markings on this supposedly non-toric lens. Um, Checked the packaging again, very definitely not a toric lens on the stickers on the injector and also on the box. I'd be interested to know what you would do in that situation, but it struck me that I had a 50-50 chance now that this was a regular lens which had been inadvertently marked with toric alignment markings, in which case I should leave it in the eye, or it was a toric lens which had been inadvertently put in the wrong box, in which case I should explant it. And I mean, I don't know. And I didn't have on-table refraction or anything like that. So I thought, well, if it is a toric lens and I have to take it out, well, that will declare itself over time. And if it isn't, I'd rather not make a bigger incision, potentially, compromise endothelium, chopping the lens up in the AC and all of that. So I left it in, and I explained it all to the patient, who was very good about it all, and refracted him a couple of weeks later, and he had about two or three diopters a cylinder. So we took him back to theatre and explanted and put a new one in. And he'd come, I think he was 6'18" pre-op, and he's now 6'9" with N5. He's a bit myopic, which is a bit of a surprise. And I yagged him the other day, but it really shook me, as you can imagine. And I think it shook you as well when I sent you the photos of.
Absolutely right.
And I think one of the things that occurred to me was it was obvious that it was the wrong lens, or the issue with the lens was obvious because of the toric markings. But had it just been another, it was I wanted a 22, but it was a 26 that went in. They obviously look exactly the same under the microscope, and you just wonder how many, refractive surprises that we get, which thankfully are pretty uncommon, and not because of biometry issues. They're not because of, other pathology, but they're because actually it was never the right lens in the box in the first place. And you'd like to think that these things, that it's impossible for them to happen. But, I stand here as witness that it happened. So yeah, so an uncomfortable moment, that one.
Well, I'd love to say unequivocally, Sam, you handled that beautifully. I'd have done the same thing. I probably would have rung a friend on the day just to hold my hand a little bit. But
Well, I sent a text. Well, in fact, I called the rep, who I get on with very well, from the company, and I said, what's the drill here? And as I say, we took. I've got some lovely photos of the lens, in the bag, lovely bright red reflex. Um, and they did an investigation, and they couldn't find a cause for it. And with another hat of mine, I run a medical devices business as well, and the consequences of this sort of thing from a QARA point of view, are huge, and particularly now with the MDR rules that govern medical devices, it's massive. So, but these mistakes do happen. There wouldn't be these processes if these mistakes didn't happen. But yeah, I hope it never happens again.
I think your patient was extremely lucky to have you looking after him. So well done. Now, listen, you've worked in lots of surgeons in many different locations. Who would have you do your own phaco?
Well, a bit like the lenses, I just think there are too many good surgeons around. I'd actually, there's very few. Maybe the question is, who would you not have do your phaco? And actually, there's not very many that would be in that list. But because it won't actually be tomorrow, I think what I would do is, when the time was coming, I think I'd make friends with the scrub team, and I'd take them out for a drink, and I'd ask them who they'd have do their cataract, and I think I'd book in with them. I think we're visitors to their domain, really, aren't we? They see it all, and they quietly, silently watch it and have their own thoughts. And so I think I would ask the boy, the guys in theatre who they would go for.
Sam, that's very sage advice. The fire behind you is dying. It's been an absolute delight to chat with you for half an hour about cataracts. And thank you so much, Sam, and good luck with everything that you're involved in.
Well, thank you, Simon. It was a pleasure. I really enjoyed it. Thank you.